Hi, very good evening. I hope you're all doing good. Hi Srish, hello Bernice, after a long time. Hi Priyanka, hi Guruparan, Shruti, Vidhi, hi Ajaj, hi Shri Kavya, hi, a very good evening. So today we shall discuss the next set of questions which I posted in Google group this afternoon, right? I hope you have gone through the soft copy. So we'll go through the discussion pertaining to these multiple choice questions, right? Yeah, so we'll start with the first one. Hi Nair, good evening. Yes, so coming to the first question. ORF stands for oncogene relative fraction, open reading frame, oil related fraction in blood, oncogenic removing frequency. So among the given options, what does ORF stand for? ORF. Hi Varun. ORF stands for oncogene relative fraction, open reading frame, oil related fraction in blood, oncogenic removing frequency. Hi Nihar. Hi Nandini. Good evening. Yes, ORF. Hi Rupali. Okay. Do you want me to give the answer or do you want me to wait? Wow, Bernice. So you've become the master in PG prep. Yes, Rupali, good. Hi Akshaya, good evening. Open reading frame. Yes, it's nothing but the sequence of DNA which starts with initiator codon and ends with the terminator codon, right? So the sequence of this specific DNA is called as open reading frame, and it is known that this open reading frame sequence, specific sequence, can have potential to code for a polypeptide, right? So ORF stands for open reading frame. Hi Purvil, hi Nabila. I'm sorry. Hi Neelaba. Krishnan, hi. Good evening. Yes. So open reading frame is a region of DNA sequence that begins with an initiator codon and ends with a terminator or stop codons. So this sequence of DNA has a potential to code for proteins, polypeptide chain. So can you give me an example for initiator codon? Hi Arjun, good evening. So give me some examples for initiator codons, stop codons, and nonsense codons. So all this you might have come across in your +1 and +2, isn't it? Okay. Yes. Nonsense codons, UAA, UAG, and UGA. Yes. Hi Vedant. Yes. So initiator codon, for example, ATC, and stop codons, TAA, TAG, or TGA, right? So a specific sequence in DNA which begins with an initiator codon and ends with a terminator or stop codon is nothing but your open reading frame, right? So it is the longest frame which is uninterrupted till you come across a stop codon. Yes. Good. So one example for initial recognizers said yes. Also ATC and stop codons, you have TAA, TAG and TGA, right? So ORF stands for open reading frame. Option B is the right answer. Now, the second question. Fibrin degradation products are helpful in diagnosis of DIC, thrombocytopenic purpura, hemophilia, thalassemia. So which one is more appropriate? Fibrin degradation products are helpful in diagnosis of So fibrin degradation products are also called as fibrin split products. So what is DIC? Can you expand DIC? Yes, Kamudi, good. Disseminated intravascular coagulation. So there is formation of multiple clots all over the vascular system, as a result utilizing all the clotting factors including the platelets. So you have a natural way of dissolving clots. So plasmin helps in dissolving clots and forming this fibrin degradation products. Since more number of clots are formed, so more amount of fibrin degradation products are formed. So these fibrin degradation products or fibrin split products, also called as FSPs, are raised in various thrombotic states or thrombogenic states, which includes DIC, disseminated intravascular coagulation, and also deep vein thrombosis and pulmonary thromboembolism. You can just make a note of these three conditions. So fibrin split products, FSPs, are raised in cases of DIC, right? Pulmonary thromboembolism, and also deep vein thrombosis, DVT. One, two, and three. Okay? Yes. Disseminated intravascular coagulation. So obviously, fibrin degradation products help in diagnosis of option A, DIC. Okay? And also in our E-classes, we have discussed about various coagulation tests, their normal range, and what exactly they assess, and various disorders in which there is abnormal coagulation test, right? So all that we discussed, you can refer our E-classes, general path section for more information, right? Okay, coming to the third one. Components of innate immunity. Components of innate immunity that are active against viral cells include B cells, memory B cells, natural killer cells, cytotoxic T cells. Components of innate immunity that are active against viral cells includes B cells, memory B cells, natural killer cells, cytotoxic T cells. natural killer cells, which are nothing but a type of a subset of lymphocytes which are larger comparatively, and they mainly contain heterophilic granules. Hence, they're also called as large granulated lymphocytes also. So these natural killer cells act as cells of first line of defense against various malignant cells, as well as cells which are infected with viral cells, viral infected cells, right? So natural killer cells are part of natural immunity or innate immunity, and they do not require any prior sensitization by antigenic contact. Okay, so components of innate immunity that are active against viral cells includes natural killer cells. And also you can make a note that these natural killer cells are part of innate immunity, which do not require prior sensitization by antigenic contact. And these are first line of defense against various neoplasms and viral infections. They constitute around 10 to 15% of peripheral lymphocytes, and they contain abundant heterophilic granules, hence called as large granular lymphocytes. Large granular lymphocytes. Okay, and also these secrete various cytokines like tumor necrosis factor alpha and granulocyte macrophage colony stimulating factors, GM-CSF. And these are also considered to be important source for interferons, which are produced by viral infected cells. Right, so some important points pertaining to natural killer cells, and these cells do not contain any T cell surface receptors or immunoglobulin receiving receptors, right? So the cell surface is free from all these receptors against T cells or immunoglobulins. Okay, we just make a note of these points pertaining to NK cells. So option C is the right answer. To come to the penultimate question, biochemical change seen in Wilson's disease is urine copper is normal, urine copper is decreased, serum ceruloplasmin is increased, urine copper increased and serum ceruloplasmin decreased. So what changes do we see? Biochemical changes do we see in case of Wilson's disease or hepatolenticular degeneration? Yes, Richa, Nihar. Yes. So this hepatolenticular degeneration or Wilson's disease is autosomal recessive disorder associated with copper metabolism, right? So first make a note of various changes which we observe in biochemical point of view. Serum ceruloplasmin. Ceruloplasmin is nothing but the storage form of copper in case of liver. Serum ceruloplasmin is decreased. Yes. And coming to copper content, in fact copper gets accumulated in different parts of the body including liver. Increased hepatic copper content. And what happens to urinary levels? Obviously the urinary levels of copper increase. And coming to the levels of copper in serum or in plasma, it's variable. It can be low, it can be high, or it can be normal. Hence, it is not used for diagnostic purpose since it is unreliable. So, in fact, depending upon the stage of the disease, we have varying levels of copper in serum, right? Apart from that, Wilson's disease, various changes include decreased serum ceruloplasmin, increased hepatic copper content, and increased urinary excretion of copper. Right? So Wilson's disease is hepatolenticular degeneration It's an autosomal recessive disorder of copper metabolism, right? Make note of that point. And also there is increased total body copper with excess deposited and as a result causing damage to various organs. And copper is absorbed from stomach as well as from proximal small intestine, absorption sites from stomach and proximal small intestine, and it is stored in liver in form of ceruloplasmin and it is excreted in bile, right? That's a normal case scenario. And we have one characteristic ring formation in case of Wilson's disease at the junction of cornea and sclera. If you remember, it was discussed already previously, and it's considered to be a characteristic finding in case of Wilson's disease. A ring formation, greenish brown discoloration at the junction of cornea and sclera. What do you call that ring? Good. Yes, Desha, Nihar, good. KF ring, Kaiser-Fisher ring at the junction of cornea and sclera, which is green-brown discolored ring, right? Greenish-brown discolored ring at the junction of cornea and sclera. And in case of copper toxicity or overdose, we give penicillamine, which is a copper binding agent. Penicillamine, 1.5 grams per day. Drug of choice for copper poisoning. And copper is absorbed from stomach and proximal small intestine, right? So, few important points pertaining to Wilson's disease: hepatolenticular degeneration, autosomal recessive disorder associated with deranged metabolism of copper, increased deposition of copper all over various organs leading to their damage. Okay, now coming to the question, biochemical change seen in Wilson's disease is urine copper is increased and serum ceruloplasmin decreases. Option D is the right answer. So we'll proceed with the final question. In case of HIV patients, which of the following cells are affected the most? Cd4 Cd8 monocytes and macrophages. Yes, Akshaya, Nihar. In case of HIV, immunocompromised condition, which cells are commonly affected? Yes, Bernice. So in HIV there is immunosuppression, especially T helper cells, Cd4 T cells, which is a characteristic finding of HIV. There is decrease not only in the number of Cd4 cells but also in their function. The quality of cells is also affected. I mean, the remaining cells which are not still dead. So most of their production and number will be decreased, and also the remaining viable cells function is greatly affected in case of HIV. And what is the normal Cd4 Cd8 ratio, T4 T8 ratio? We have discussed this previously before NEET 2018 also. So what is the normal ratio and what happens to this ratio in case of HIV patients, the ratio between T4 and T8 cells? Yes, Rish, Richa. Yes, Bernice. The ratio is affected. Okay. So what is the normal ratio? Yes, you're right, Bernice. We have around 400 cubic millimeters approximately the number of cells. Cd4 and Cd8 can be 200 to 800. So the normal ratio is between 1 to 2. In case of HIV, there is actually inversion. The ratio is usually less than 1 because Cd4 cells are affected, are the primary targets. Okay, good. And it's wonderful to see that you're still involving actively in discussion. Keep it up. Right? So this completes our today's discussion. We'll have a summary of all that we have discussed so far. So regarding open reading frame, it's mentioned that it's a sequence of genes or DNA nucleotides from the initiator codon till a stop codon has been phased or has come across. So this open reading frame is known to code for a specific sequence of polypeptide. That's nothing but a protein. And also fibrin degradation products or fibrin split products, they increase in thrombotic stages, which include a DIC or pulmonary thromboembolism, or it can be deep vein thrombosis. In any thrombotic states where there is excess clot formation, obviously there is plasmin in your body, a natural way helps in degrading this fibrin into and splits them into fibrins and then converts them into dimers, in fact, forming fibrin split products, right? So elevated levels are useful in diagnosis of these following conditions. And also we discussed about natural killer cells, which are known to be the first line defense against various tumor cells as well as viral infections. So these are nothing but larger granular lymphocytes as they contain azerophilic granules, right? Hence also called as large granular lymphocytes, natural killer cells. And also we have discussed few points pertaining to Wilson's disease, abnormality, autosomal recessive disorder of copper metabolism, hepatolenticular degeneration, increased deposition of copper in liver, and also there is decreased ceruloplasmin in serum and increased excretion of copper in urine, few biochemical changes, right? And also few important points pertaining to copper metabolism in Wilson's disease, KF ring, Kaiser-Fisher ring, right? And also we discussed about the role of Cd4 cells or their fate in case of HIV, right? So usually in case of HIV, Cd4 cells are targeted and their number and also their function is greatly affected. And there is inversion of T4 T8 ratio, the normal being 1 to 2 in case of HIV or immunocompromised hallmark situations. Immunocompromised Cd4 cells are greatly affected, as I said, which is considered to be the hallmark of HIV infection. The ratio is inversed or it is less than 1. Okay, so these are some of the important points which I wanted to discuss in this live session. I hope you got note of few points pertaining to the same, right? So if you have any further queries, drop them at proudtobedentist@gmail.com. Hi Sanjay. Yes. You're welcome, Bernice. And see you again next week. Next Wednesday and Thursday, we'll come up with the next set of questions from General Path. In fact, we're following our October batch schedule. And once we start with our Mission 12 batch, we'll be incorporating those schedules also in our live sessions. Okay? Yes, Focus Nochi. Regina is missing again. Yes, Richa, Akshaya, Arjun, Srish, Bernice, Anaka, hi. Yes, you're most welcome. Right? See you again next week. Bye. Take care. Love you all. And those are appearing for 2019 NEET, make sure that you're live this Sunday. We're having few orientation lectures. Okay? Bye.